Developmental pediatrics sits at the top end of community pediatrics because developmental problems are so much that it percolates into the community. Visible disabilities take a little longer than the invisible disabilities. With autism, ADHD, learning disability, we can show them results within 3 months' time. We are producing professionals who have got this entire understanding of how, being a non-curable condition, you can have a perfect treatment so that you can lead a perfectly healthy, normal life.
Hello everyone, welcome to India Autism Center podcast, your safe space for powerful and insightful stories on autism, neurodiversity, inclusiveness and overall community empowerment. I'm your host for the session, Ms. Pooja Datta, and today we will be focusing on a very crucial topic that is very close to most of the parents out there. Yes, we will be talking about the role of a developmental pediatrician in autism assessment as well as management. Today we have with us Dr. Anjan Bhattacharya. He is one of the leading developmental pediatrician in Kolkata, and he will be giving us the essence of what a developmental pediatrician does and how he contributes in the multidisciplinary team for autism care and management. Welcome to our show. It's a privilege to have you over here.
Thank you. Thanks for having me. I'm fine.
Sir, please share with us a brief professional journey of yours and how did it align with autism care? What made you come deeper into the world of autism?
Good question. So my journey starts back in the UK, where after doing my post-graduation, which is MRCPCH, member of Royal College of Pediatrics and Child Health, UK, I was still searching for this answer which I was not getting. And I didn't know at that time that there is an entire world which they call community pediatricians. Developmental pediatrics sits at the top end of community pediatrics because developmental problems are so much that it percolates into the community. So learning about all these things, all the children with special needs, what is the right protocol and what are the right procedures, I thought I had two choices. One choice is go back to India and try something similar that I have witnessed there, the model in UK. The other option was to continue my career over there, which was anyway very nice, very cozy, but I was not comfortable just doing that. So I had to take a leap of faith. When I came down here, I found myself in a space which is almost untouched of. There was one child development center in Kerala, Trivandrum, which our guru, Professor N.K. Sinaya, the doctor who retired as a vice chancellor of Trivandrum University because of his pioneering work in India, and few standalone centers, but more myths than facts. So I was quite astounded because my aspiration was to develop child development center, and I believed that if we want to give treatment for special needs, the whole entire group of special needs, then we need corporate healthcare, because India is a country where the private healthcare is the largest contributor in the world compared to the division between private and public. UK is the least, means everything in UK is done by the government, and in India the highest number is done by the private. So our salvation for special need children would come if we could actually put it in an organized private space, which is the corporate healthcare sector. So I chose Apollo, and I'm very happy to say that Apollo entertained this idea. It doesn't necessarily make business sense, but they were great in terms of giving and allowing me to do what I wanted to do. So I have been very fortunate to establish India's first developmental Child Development Center in Indian corporate healthcare sector, in Apollo Gleneagles Hospital, Kolkata, which is now called Apollo Multispeciality Hospital, Kolkata.
Sir, I really hope that today we will be really getting some good inputs from you. And this awareness really matters a lot for the parents sitting right there. To start with the basics, what is the role of a developmental pediatrician? And how does this differ from child pediatricians or a child psychiatrist?
Very good question. So we are the first 15 fellows, honorary fellows of Indian Academy of Pediatrics to start our fellowship program. I'm now an external national examiner for the fellowship program of Indian Academy of Pediatrics, and we now have more than 100 fellows who are developmental pediatricians. In 2016, Indian government have accepted autism as part of the child disability. Before 2016, legally, autism was not part of child disability. So that journey started around that time. So 2015 was the year when 15 of us were developmental pediatrician. 2016 we had that Disability Act, which has been ratified on 18th of April 2024. And in this ratified act, we have a nomenclature called developmental pediatrician, which is fantastic because in Indian Gazette, now this is now a recognized branch. So question is, what do I do? And this is a question I had to tackle from our fellow pediatricians, let alone fellow physicians. So it is not a wonder that you are asking now. Now it has percolated into the community. Even community is having to learn about it, simply because, if you have, suppose a tummy ache, right? Who do you go to usually?
A general physician?
Correct. Suppose the tummy ache is not being resolved by the general physician, then what is your next port of call?
I look for specialists, and
For example?
maybe I may go if it is a problem of gastritis. The physician indicates I'll go to a specialist, a gastroenterologist.
Correct.
Or
Would you go to a neurologist for this?
no.
No. Exactly similarly, the developmental pediatrics journey has started. So now it is very easy to explain, but to understand this, the reason Indian government took such a long time to understand and acknowledge, and I'm not blaming anybody, I'm just saying that these things take time, right? So developmental pediatricians are very rare resources. The reason being that it takes a lot to become a developmental pediatrician. The remunerations are not that lucrative. The effort that a surgeon puts in becoming a surgeon, their remuneration, although they have a much harder life, but for a developmental pediatrician, the life is no less hard, although it doesn't show. It's not that heroic looking. And that's why the remunerations are also not that much, because developmental pediatrics is full with people who are more giving in mentality rather than taking. So, we also don't ask for much. So, this is a hindrance, I would say, in terms of the discipline going ahead all over the world. So, last time when into 2016, the developmental pediatrician retired in Alaska, in USA, they needed 2.5 years before they could fill up that vacancy for the next developmental pediatrician to find. Why do we need them, right? Because the care is complex, and the care becomes inordinately complex without the expertise of a developmental pediatrician. So if you have a competent developmental pediatrician, that complex care seems very easy. Not so easy as you would go to a gastroenterologist and he will come with some medicine, or he will suggest a surgery, and your misery is over after that course of the medicine or the surgery. Developmental pediatrics take a little bit more time. So we were discussing, I see less cerebral palsy and more autism, simply because with autism, ADHD, learning disability, we can show them results within 3 months' time. Very quickly we can show them results. This thing, albeit it's quick, But for parents of cerebral palsy, it doesn't feel quick simply because it takes a little longer. Even if that becomes 9 months, you can imagine our population can't understand that they might need to wait for 9 months to get a flicker of improvement to be seen, because visible disabilities take a little longer than the invisible disabilities.
So, sir, you said ki there are certain quick fixes, and you also stated about the model, which is Kolkata-based model. Can you please tell us parents, like parents will also be, keen to understand, because we know autism is not curable. It is a condition. So, what are the sorts of quick fixes, and what is the model you are talking about?
Actually, when you say autism is not curable, what we forget is that none of the non-communicable diseases are curable. Like, you have glasses, I have glasses. We suffer from a non-curable long-term condition. We are not moaning about it. We are not saying that, the sky has fallen on our head. But for historical reasons, autism has got this stigma, which is very sad. I have diabetes. I don't have problem in living my life normally because, whatever the treatment and management of diabetes is, I follow and I enjoy my life exactly as another person. That, if you don't have diabetes, the quality of life that you have, following those management strategies and treatment, I have the same quality of life. There is an effective treatment of autism. It is published in the best possible journal in the world, and it is published by Impact Study done in UK. It's a multicentric study. It was published in 2017. It is 2025. If we still say that, it's an incurable situation, so all hell break loose, I think there is something wrong there. And I believe that what is wrong here is the competence. So we are developing competence. We conduct the postgraduate diploma in early intervention for neurodevelopmental disorders, and we are doing this under the West Bengal University of Technology, which popularly knows as MACOUT. So we run that MACOUT course, and this is the 4th year it is running. We are producing professionals who have got this entire understanding of how, being a non-curable condition, you can have a perfect treatment so that you can lead a perfectly healthy normal life. And none of our children at our Child Development Center ever needed to go to any special schools. They go to mainstream schooling, 85% of them, because in every treatment model you will have a group who will not succeed, not because our treatment is a problem, but because of their own problems. But 85% of our parents engage, and whoever engages, eventually they get out of this problem. Our average length of this placement back to mainstream schooling is about 8 months. But there are extreme cases who have gone on for years before they could be placed. So these 85% children are happily talking, they're studying, doing dance, drama and everything with able-bodied ones. So we do not consider our model successful unless they succeed competing with the so-called normal children in normal schools, in normal things, not just education. So if our child do not succeed in being top 10 in the class and get some medals in the sports and some in the dance, drama, music, whatever extracurricular they might be choosing, drawing, painting, we don't consider that as a success. So we have a lot of success stories.
Yes, sir. We'll be surely, asking you to share some success stories. Sir, before that, you are known to use many structured tools for assessment of autism. Like you use ADOS, ADIR, Griffiths and Bailey's scales as well. So for parents out there, many of these terminologies may appear new to them. So can you please explain when these tools are used, in identification of the condition?
Again, we go back to gastroenterology because, it took a long time before people understood the word ultrasonography, which then became USG, then it became scan, then it became endoscopy. Lay people started understanding these terms. Same thing is happening here, nothing new. So these are tools through which we diagnose using gold standard assessment methods. And these are the things that I have learned back in UK, and I have started using them in India. Gradually, they are getting validated in India as well. Like Bailey's scale has been validated now, and we were part of that validation as well. So the Bangla validated Bailey's will be coming very soon, probably end of this year only, and we'll be delivering that. We spoke with the PG hospital, and we'll be doing that research together. So you can understand that, whatever is science, eventually it will win over. And science tells us that there is an effective treatment for autism. So how we reach that science? We reach through gold standard assessments. And it needs to be done by a competent person, and we are building skills for that.
So, sir, how are these assessment tools different from the so-called assessment tools that are traditionally used?
Right. So, traditional use tools do not have the equivalent rigor of, the predictive value, the sensitivity, the specificity. If we actually develop something ourselves that way, it won't be bad, but all effort so far has led to the same conclusion that whatever is already being discovered as gold standard is good enough. Basically, we have reinvented few wheels, but it had not added to our armamentarium of knowledge. So, one of the conclusions that we can draw from that is that rather than reinventing the wheel, let's polish the wheel that we have and shine it and let it run more smoothly like a ruler table.
What are the red flags that the parents, they should notice in children, and even you observe you before doing an assessment, and conveying to the parents that further assessments are needed? How do you convey that to parents?
Fantastic. Before I answer that, let me give this information because this may be new, although we are doing it from 2017. Today, there are accepted, validated, and widely used international tools that can detect risk of autism at birth. So we go from that. Leave that out. Then you have little red flags coming up, and you don't know whether it is autism, it is developmental delay, it's ADHD, it's learning disability, or it is even cerebral palsy. But look at all the red flags together, right? And it depends on age. In infancy, you might see that the child has not done the social smiling in time, right? You smile at the child does not smile back as quickly as a normal child should, or does not smile back at all, or does not really look at you, or might not turn towards sound, or might not really seem to be turning with eyes and fixing their eyes. So that is called fixing and following. So all these things can be all these four conditions, and we don't know which one is which. And then this is the value of screening tools. So come next year, we have a screening tool called MCHAT, Modified Checklist for Toddlers of Autism. And this now is MCHAT RF, so that is revised and follow-up. So you do that, it's a revised MCHAT and with a follow-up module to it. Why we have a screening tool like that? Because it might not be the sensitivity of the tool might not be good with single assessment. You do a follow-up and then you can tell whether you are really into a danger zone or not. When you do the follow-up later after intervention, early intervention, then you can also assess whether your problems are going away or staying back. Then as the age progresses, you already know that the child is not responding to you, or is talking but not talking making sense, or talking gibberish, or not talking at all, or is very shy, so shy that it is difficult to get him out and mix with the peers, with the relatives, with social things. So that this is a reclusive child, wants to be alone. You go a bit further, then you have got a child with a lot of problems, behavioral problems, educational problems. There are so many that in this short space, rather than saying them, if I say that if you, in today's day and age, science has shown us time and again by now, that if you suspect that your child is not quite right, you may be wrong, but it does not harm you to hear it from an expert. Which is like, I'm presenting a conundrum to you. How can everybody can come to expert? So basically we need to create experts everywhere. And we are into that creation, skill building.
So, sir, as a parent, when I'm seeing that the child is not developing at par his age, so till when should the parents wait?
Right. So we have done a study on this, and we have found out what are the common phrases used. Like, he will talk later. His father also talked a bit late. We can all wait and see. What is the point of getting too worried too soon? So these are common phrases which we classify as a group called social validation. Social validation is a barrier to services. The services which are timely services. So the window of opportunity goes away because of social validation, and we presented this poster in an Australian medical conference, and this study was done by one psychologist of our team, and we have sent two posters basically. Quite happy to say that these two posters were given the ranks of top 10 in the world. So we hold it dearly because all the doctors and everybody else were sending their posters throughout the globe, and two posters from Kolkata Center, one Kolkata Center has bagged top positions. One of them is on social validation. Nowadays you will see lot many more papers coming up on this barrier, and this barrier is a major factor what delays the right treatment for the child. Because a stitch in time saves 9. What happens is, if you bring your child early, if there is no problem, we can find out and tell you about it, and it's problem solved. But those 20% where we will not be able to tell you that your child is all good, you are ahead in the game to getting it good. And you will do it cheaper, you will do it at a shorter time, a time which is so manageable that any parents can take those few months leave, childcare leave, or even casual and annual leave will cover it, and your child is out of the woods. For example, what is the benefit of getting a child risk detected at birth? At birth, we can't diagnose, right? Because child doesn't give us that much opportunity. But because if there is a risk and we intervene with expert early intervention, what we have found out recently is that, within a couple of months' time, all the symptoms have gone away. And because these are early days, we cannot say that whether the problems have gone away forever or not, but our science tells us that it should be. So the science is telling us that probably we will turn the neurodevelopmental trajectory of these children for good forever. And we are living in that hope. And we have done a subsequent study with Queensland University, Australia, here sitting in Kolkata, where a postdoc fellow came and stayed here for 2 years to do this study called LEAP CP study. The study was on cerebral palsy, but basically what we have shown in the study is that the moment you detect a risk of developmental disorder in children at birth, we might even be able to give their treatment where they are sitting at home. So they might not even have to come to treatment center.
So, sir, how is it detected? Because we should, we need to know what are the assessments that are done?
This one that I'm talking about is called General Movement Assessment. As we speak, we already have 3 trained professionals who are trained by international group. They are from Austria in Europe. They have trained us and accredited us, because you need to be accredited to practice this. And since then, we have given this training to about 1,000 professionals all over India, like, Maulana Abul Kalam Azad Institute of Child Development Center in Delhi, St. John's Institute in Medical College in Bangalore, right? Similarly, there are 5 centers, like, one in Mumbai, one in Varanasi. We have 5 centers doing this training in 2018. And the 3 of us who are trained in this training in Kolkata, we are all trained in advanced GM assessment, which means that we can do a optimality score. We can accurately measure with a score to tell that your child's risk is this much, right? So right now, we have a professional who has passed that postgraduate diploma in early intervention, MACOUT course, right? Who have passed from our center. And today she is in Mumbai. From tomorrow, she is going to be trained in this. So we have been doing it in Kolkata before. Now it's Mumbai who is doing it. So she has gone there to get trained. What we want to do is that, we want to pick them early using gold standard methods, international methods, which are all applicable all over the world. Most of the developed countries are using it. And if we use it, then we can actually probably alleviate the risk of disability from before they become manifest.
Sir, it really sounds very promising. And I'm sure parents watching there, even they are getting this, hope that definitely things can be done if earlier intervened. Sir, when a child comes to you with concerns of speech or social delay, what is the step-by-step process of evaluation, if you can tell that, and how do you balance your clinical observation with the standardized tools?
Fantastic. Observation is the key to clinical practice, but observation can so easily go wrong. I'll start with autism mimic. So a Bengali child comes back from Australia very recently. The child is still in our caseload, where we have, made initial contact. They came and said that, child has got autism, but still, not getting better, not as much as we have hoped. His problems still persist. So we have then done the screening, followed by the confirmatory tests. And we have a methodology where all the test results come back. We sit and then deliver the news to the parents, which we called breaking news. So before breaking news, we sit down and, shift through the results of all the tests, which are all telling us that he does not have autism. So what does he have? And we find out from one of the very simple tests that somebody has done in Australia, which tells us that he has a lacunar infarct, which means that there is a damage at the time of birth or before birth in the brain, in a place which is known to mimic autistic symptoms. So this is a classical autism mimic. So you could tell the parents, and they're still coming for the difficulties the child still has, but these are not due to autism. So the treatment modality varies. And the child is improving much faster than a child with autism.
At times, even the parents are not aware. They suspect that it is autism, and the child carries the label of autism spectrum disorder.
It's simply because we don't have in India all the gold standards which we have been practicing for the last 18 years. High time, all these things are done by everybody.
True. So, sir, now you are telling about these gold standards, and we know there have been traditional assessment methods as well. How far parents are receptive to these gold standards of assessment?
As we have said, we have 85 of our parents cooperating with us, and that is why we have such a huge number of children who are going back to normal lives. They still have autism.
But they are able to function well.
As normal as you wouldn't know.
So, sir, we know autism, it is the management is also multi-layered, as is the spectrum. What is the role of a developmental pediatrician when it comes to multidisciplinary team?
It's care coordination, and it's expert care coordination, right? You need to know exactly how to pace it, how to deliver it, which professional should do what. I can take a very easy example. For the last 3 years, like 21, 22 and 23, I went back to UK and did locum consultancy, means part-time consultancy jobs over 3 months as a chunk in 3 different places in UK. First one was near Liverpool, second one was in Stevenage, which is near London, and the third one is in London itself, in my own place of work. Just because I wanted to see that, is there any updation I'm missing? Not much. One big updation has happened is that, today if a child is suspected to have autism and probably is on the autism diagnostic pathway, if you send this children to speech therapist over there will return back saying that, it's autism, what have I got to do? So this is something that we can easily do, because in the India's first corporate child development center, we have never used speech therapy as a modality of treatment management, not for autism. Okay. That's why probably we succeeded quickly.
Okay, so
we use the science.
Sir, is it not the assessment that is done by the multidisciplinary team as a whole?
Everybody does their own assessment. That way we have peer reviewing. And because they're independent assessments, we match that during a multidisciplinary meeting. Parents are there. Everybody has to present their cases. We see whether we have mismatch or not. And I'm very, very pleased because, our professionals are trained abroad, basically, mostly. The senior ones, junior ones are coming up very much, so we don't see the need to send everybody abroad. We now have the standards, at least in our place. So, but our first generation of people, the senior ones, they are all trained abroad. So basically, when we see their independent assessments are all matching, we keep gaining in confidence, and the parents keep gaining in confidence, and the child keeps gaining in confidence, and we all, with our enormous confidence of nobody's making one bit of mistake, we really give this fast delivery, which would have happened in cerebral palsy if we could have got parents to persevere. If we didn't have other alternative that are available, if we worked collaboratively, then we would have done a much faster and quicker job, even for the children with cerebral palsy.
True. Sir, you just previously said, and that really intrigued me a lot, there are certain conditions that mimic autism. So
huge number.
The incident that you said, that was biological, but we often see individuals, they are coming with their children and they are mimicking the symptoms of autism, and autism is being diagnosed, but later it's being ruled out. There may be some social factors which even lead to autism-like symptoms in children. So can you please elaborate on this, because parents even need to understand this, because they get very apprehensive, and at times the spectrum is overdiagnosed in children as well.
We recently diagnosed a child with isolated speech delay. And parents were absolutely sure that this is autism. Somebody probably have told them already. So, the journey that this child took, again took 3 months, simply because somebody has told parents something which created a huge panic in them. So managing parental panic was our main objective, because the condition isolated speech delay is such a simple one that, you wouldn't need 3 months to deal with it. And this is one place where a bit of speech therapy might be necessary, because if the age is beyond 8 years.
So does it mimic autism-like conditions, like, sir,
yes, it does.
Eye contact?
Yes, it does. There are other things like, FLI, familial language impairment. So entire family looks autistic, right? But it's not autism. We had a case child from Bombay. That was a long time back. That was the first time, when I presented it in Indian Academy of Pediatrics, they got kind of silent after hearing, and they started learning about it. So yeah, there are huge number of conditions, about 1,000 language disorders which can mimic autism. One is Tourette syndrome, one is Landau's cleft syndrome. You can name many, PLI, pragmatic language impairment. Not everything is autism.
True.
That's why we need a gold standard diagnosis. Otherwise, even we will miss it.
Yes, and these tools, these gold standard tools, they exactly give us that understanding.
Not necessarily. They may be confusing as well. And that is why you need a developmental pediatrician. So the final call comes from the expert, weighing all these information together. And that is how it is gold standard.
Okay. Sir, let's address the diagnostic timing. What, in your opinion, is the ideal age to have a formal, complete developmental evaluation of the child?
This, as we have said, we can do it from day 16 of age, because the Bailey's tool is validated from day 16. And we can diagnose the risk at birth, right? The diagnosis itself, using EDOS and ADI and all that, we can't do it before 1 year of age. But surely after 1 year, we have got all these tools.
Where a formal diagnosis can be done.
Exactly, because there is an infant module. So we can do it.
Sir, at times, again, being a parent, I understand, putting a label on the child, it is unexpected for the parents. At times, they are in denial mode. So, how far do you think a diagnostic label is needed for management?
Yeah, I think that question really comes from our old model. The first model was called biomechanical model. You have a bendy leg. Let's mend that bendy leg by surgery, by stretching, etc. So this is the biomedical model, biomechanical model. In short, it's called medical model. That was 1950s. In 70s came the social model. That, oh my God, this is not only a medical disease. You need to be compassionate and you need to give sympathy and all those things. It failed. It really failed badly. And then came the developmental model by the turn of millennium, right? So it's about quarter of a century old model, which is the latest model, which in India is gradually catching up. Your question probably comes from the previous generation's stuff, the social model. They have a problem with autism as a name. They had a problem with asthma as a name. We couldn't say that, this sardi khansi is basically asthma. We couldn't say that. Today, it's not a big deal. Because, we say, you can say it's sardi khansi, you can say it cough and cold, you can say it asthma. How does it matter? Similarly, if we really forget about all these social models, we come to the developmental model, autism, so what? They're leading all these fantastic lives. What is the problem? They are leading as normal as another child. They're succeeding in academics. They're doing everything that another child with autism could do. Maybe better. Maybe better. Actually, because they're getting some intervention, our kids are actually doing better than so-called normal peers. Like, we have Saraswati Puja. This is started by somebody called Shairin Ali, who started our Saraswati Puja at our center, which is going on for last 5 years. And in this puja, what is fantastic to see is that, you go there, you will see about 40 children, some new, some old. All of them have got some or the other, mild, moderate, severe, profound, everything. But we never had to really manage them, do anything special. They will not touch anything. They will not go and destroy anything. But go to the next center in your mohalla, right? In your locality, in neighborhood, you will see normal children wrecking the place up. Our children are doing so much better. And that's what competent intervention does. And because this is a sustained and over the year and year after year thing, this stigma is an invention of people who are not dealing with it competently. I really hate it as a stigma. It's not a stigma. I have myopia, so what? My father's elder brother probably would have bothered by having it and denying it and trying to hide it and dying early because he was trying to hide it, was not getting the treatment. If you give the right treatment, what the heck? Why are you bothered?
It is about mindset.
It is about mindset, and we all need to come together and change in a big way, because it's causing a menace, saying that we have to accept them, world had to bend over backwards to accept them. We don't. We need to give them the right sort of intervention so that they can come to our world and mix exactly the way they want to. I have not seen one child unhappy being included in the normal world the normal way. I have not seen one who complained that why have you changed me into a normal. I have not seen one child complaining. They're all happy.
Sir, are there any common misunderstandings or misconceptions regarding the role of a developmental pediatrician, and what a developmental pediatrician does and what he doesn't do?
So misconceptions were abound. Of late, sitting in where I practice, I'm not seeing that much. And the conferences I go to, I don't get to see that much. But I'm pretty sure it must be existing. So some people might think that, this is another fanciful new stuff. But they don't complain about having pediatric eye specialist, pediatric dental specialist, pediatric neurology specialist. All these things can be pediatric, except development is very queer something. Why would not? Development is mainly has to be pediatric, right? Of course, developmental disorders can percolate into adult life, causing havoc. But it doesn't. It makes sense to have developmental pediatricians. Pediatricians need to specialize in their developmental stuff. It's not everybody's everyday stuff. I've just given you already some examples. So that is why you have to do that. So what a developmental pediatrician do is that they focus on child's developmental disorders. Or if you can say what to say conditions, I don't have a problem with that. So asthma is a condition. It can get better, it may not get better. We cannot determine that. There is no predictability which one will get better or not. But one thing is sure, that if you take the right treatment, the chances of getting better is so much higher. Right? So this is how we must understand that if we involve developmental pediatrician dealing with developmental conditions, the chance of that child is so much better, because they're specialized in that. So we must understand what a developmental pediatrician does not do. So he does not delve into others' role. Like, a developmental pediatrician should not be doing the day-to-day pediatric stuff, or a pediatric neurologist job, or a pediatric psychiatrist job. Right? So that is what developmental pediatricians do not do. They pick out that whether this child with developmental disorder also have something which will need another specialist. And they refer for. It's a very easy example. In our child development center, because we have a multi-speciality hospital, we also have a equally competent pediatric neurologist. He doesn't see the developmental cases. I do not see the neurological cases. So if a child comes with autism and epilepsy, he will definitely have a referral to our pediatric neurologist. This is how we do it, because this is how we would have done it in UK. I have done that in UK. I do that when I go back to UK. I do not see my children of India, any less than any child of UK. I do not treat them any less. And that is why we do the right practice.
Sir, the way you are speaking, that shows what you are saying. Actually, you are preaching that, and the prognosis, the recovery is quite high in children.
And we have got our thriving internship program. So about 100 interns. This year it's 200 plus, right? So at least all of them are getting to see that as well, year on end. Last 5 years we are having 100 plus interns. So, there is nothing to hide. Come and see whether it really happens or not.
Yeah, it should be tested, and then it should be tried.
Absolutely.
Yeah. So, sir, before we wrap up for this session, before leaving you, we will be just having a quick rapid fire round where I will be asking, or rather where I will be stating a series of statements around certain conceptions related to autism and your field. So here we start, and you have to say whether it's true or false, and you can also add bit elaboration on that. If a child is delayed in speech, it's definitely autism.
False. Because most of these cases will not be autism.
Girls with autism are harder to diagnose than boys.
False. They're harder to pick up because they have a different characteristic and they're thought to be less common. I don't know whether they are not. They may be underground.
Hmm. Early intervention doesn't work unless the child is already showing severe symptoms.
It's too late if it is showing severe symptoms. So it's false again. So you have to do it at birth, as I am saying. Then you really take it away.
Developmental pediatricians only work with children under age 5.
No, children are until age of 18 and half of my caseloads are 12 plus.
Autism can be diagnosed using only observation without structured tools.
Totally false. I have given examples.
Yes, sir. Thank you so much, Dr. Bhattacharya, for your powerful insights on autism. And the most impactful, what I found was that the role of, being calm and doing the diagnosis, following the proper evaluation protocol without being, panicky, that works best for, individuals in the spectrum. And for parents out there, if you feel that your child's development is out of track or you are confused as to what is happening around, please, you trust your instincts, you listen to yourself, and you actively seek for help. Because seeking help early, it is not a sign of desperation. Rather, it indicates empowerment. So if you find today's conversation meaningful, insightful, and relatable, please stay tuned because these conversation matters and it is for you. So before ending up this, sir, do you have anything more to say?
We have a tagline. We say, disability lies only in the eyes of the beholder. Because for the rest, we have technology.
Right. So it is a perfect blend of science and compassion as well as care. Thank you for joining us in today's conversation. And
Thank
if
you.
today's discussion, it appeals to you, if you can resonate with this, please subscribe to our video channel, like and share our meaningful videos. And for till the next conversation it comes up, please watch the video that is popping up on your screen. Thank you so much for your patient hearing.